Thank you. Hello, everyone, and thank you for the opportunity to present today as well from Ghana land here in South Australia. I would just like to acknowledge the traditional owners of the land and everything that they've done in the past, present and future as a way of getting started. So, yes, I'm a registered nurse and credentialed diabetes educator, and have also had many years of lived experience of caring for a daughter with a disability. It certainly brings back memories listening to Trudy's presentation around the issues with dental health, and Sarah used to clamp the side of her mouth. I wish I had have known about the 2 toothbrushes back then, but we integrate. It's interesting because we do integrate dental health into the work we do with people with diabetes, because the other thing is that it's a lovely cause of high glucose levels in people that is often unidentified. So I might talk about that a little bit later. I specialise in people with an intellectual and cognitive disability or psychosocial disability and diabetes now. Sarah, my daughter, sadly died at the end of 2019, and I'd already started pivoting all the work I do to disability, but that made me decide to completely do it. She died far too early, and sadly is one of the statistics of what we know only so well. So I thought that I would talk today just about why we need support for people with a disability and diabetes with their diabetes care, what the challenges are, and how does D4D work to make a difference in that space. And then we'll have some questions. Now, I suspect I'm talking to the converted here because you're all a part of this group. And the reason that we need to do something in this space is that we have people with a disability, intellectual disability specifically, dying far too early. They have 2.5 times the number of health problems as people who don't have intellectual disability. They have higher rates of obesity, use of psychotropic medications, and polypharmacy. They have lower exercise rates, all the things that sadly set them up for greater diagnosis of diabetes. They also have a number of genetic disorders that put them at higher risk as well. They have twice the rate of emergency room attendances. And what I see is this rotating door where people will have, sadly, again, the emergency services have become the old doctor who did the house call, and often is the default mechanism for the people to get help within the support workers framework. So it means that there's a relatively low base by which to start calling for an ambulance. That then ends up in many accident and emergency presentations. It means that the person is at much higher risk of issues as soon as they hit any of those systems, because they can't communicate frequently. They do have complex needs, and they do get scared in these sorts of environments. And so it's not unusual for those events to also trigger behaviours that can result in even the police becoming involved. So we have this underdiagnosis of chronic disease. So you add on someone in pain, because frequently people have very high pain thresholds. You just have this recipe for absolute disaster, both within their health, but also for all of the services around them. And I just think at the moment, if we don't start to address the fact that this all results in people, like Trudy said, dying 20 to 32 years earlier than the rest of us, then we're not listening. and we're not doing what we need to do. The thing that shocks me the most with all of this is that this is 15 years after Australia signed on for the United Nations Convention on the Rights of People with Disabilities. And I know that you're all familiar with this, but it's worth stating again that Article 25 says that parties recognise the persons with disabilities have the right to the enjoyment of the highest attainable standard of health without discrimination on the base of disability. Now, I can't say we can tick that off. I really can't. And I don't understand why we're in that situation with all of our intelligence and resources that we have. So my sense is that people with a disability and those people who are supporting and working with them are saying it's time. It's time to change that. We need to assume that we can make a difference, that health and disability need to do it together, because currently I don't think we do that very well. We need to harness what people who do understand both those spaces and start to look at what they're evolving and see how we start to gear that up. We need to include consumers and those with lived experience when their people can't speak up for themselves. So everybody has a responsibility in this space, and including people with a disability. But if we don't set them up to successfully be able to, for example, brush their teeth or go to the doctor, know that they need to see the same doctor, the support workers need to book them for the same doctor, then we're going to continue to tread water. So, as I say, I think it's time to improve diabetes support. And if we look at it from the support workers' point of view, the quality and safety framework that we currently have within disability organisations for diabetes support is left wanting. And I have to say, as someone who ended up working closely with the NDIS to update the high intensity skills descriptors for subcutaneous injections, it was great to get the opportunity to bring contemporary diabetes knowledge into those descriptors. So I felt very honoured to get the chance to do that. However, we're not giving people enough information to know how to set their quality and safety framework up. There's too much airy-fairy language that I frequently have people asking me, what do they need to do? There's very little diabetes training that has been set up specifically for support workers. There's a lot of things that are general training, but that doesn't equip. We know we have a group of people who have frequently English as a second language, or if they were born in Australia, many of them have got a learning disability themselves, like dyslexia or other issues that impact on their learning. And so we have to start designing things for their needs. They have very little health training, and even within the disability organisations, that's a challenge. Even if you have one nurse, they're not going to be able to cover everything that needs to be done in order to cover the health side of disability support. The communication issues are huge and create big barriers to people getting the right care. There's the links between health professionals and support workers lead to misunderstanding around their knowledge and skills. And even of the health system, a lot of support workers don't have a good understanding of the Australian health system. There's poorly constructed diabetes management plans that are written by health professionals who don't know how to talk to a support worker or how to set the practical up. And I have to say, on a lot of those, the default again is to call the police or to call and the ambulance services when it all gets too hard. Now that's why would, if we wanted to set up a system not to work, I think we would tick all those things. So if we then look at the things to improve from the health professional side of things, is that it's not always set up to successfully care for people with a disability, because they're not seeing the person enough, they're not being able to see them for long enough appointments, they're not getting paid enough for the time that they need to see them. They often don't have training around the health of people with intellectual disability or cognitive disability. There's lots of communication barriers. They don't have low literacy resources. And even something as simple as a picture of where you're moving someone in emergency from the emergency space to have an X-ray, there's no pictures even. But a simple camera could actually create some great resources to stop people getting scared. People are brought to appointments by different people, and quite often someone who's just back from holidays, and so they don't get enough information about what they need either. Often information is forgotten, like blood glucose charts. So again, we're not setting health professionals up either to be able to do better in this space. So our focus with EdHealth Australia is to set the person up for diabetes health success by making their circle of support set up to succeed as well. You can't take one out of the other. I must have put up the wrong presentation.
Oh, because you had the extra slide with the resources. Here we go. I'll share it at this end if you like. I've got that.
Oh yeah, can you do that? Sorry.
Yep. No, that's fine. I'll just quickly
I've got 5 presentations I'm doing this week, all on different things. And so I didn't even change the presentation.
There were some extra slides in this one, I think.
Yeah. But I mean, I think the presentation's the same. It doesn't matter. I would say all the same stuff. So let me just go back. Oh, no, I'm going to have to get you to do it, aren't I?
Yep, that's fine.
So can I just get you to go back?
Yep.
Keep going. So let's look at strategy. One more back.
Yep.
Okay, so people, here's what we do. So we've got a suite of about 12 different services that we can provide. We focus on the disability side of their diabetes, which I have to say can be very confusing for the planners with NDIA. And it's a frustration that there's a really poor understanding around how people can use their plans to help with their health support, and especially when it comes to high intensity skills descriptors. So I'm amazed how often people aren't getting funding, for example, for needing to provide high intensity skills support. And so I'm just going to provide you with some examples of what we do. So what we do is create strategies that wrap around the individual so that they can move with them wherever they go. And we break down communication barriers so that they can better connect with the health services that they have every right to access. Where it gets tricky is that the planners don't understand that our service is different to the mainstream system, and that we're connecting people to make sure that they get their mainstream health support as well. That the resources we create then let other services do their job, but that some people need a modified education strategy, and they just don't have the skills in mainstream. They might eventually, because of the work we do, that we can end up sharing, but just at the moment, we just don't have the skill set, which is what's contributing to the higher death rate. So we also incorporate positive behaviour support. We have a lot of people who refuse their insulin, and they will do that because of things that possibly trauma-informed have happened in hospital, especially with psychosocial disability, where they've been held down to have their insulin because they've refused. So we end up creating low literacy resources, but also positive behaviour support strategies. So we had a gentleman just recently who has been refusing to have his insulin for years, and we set up a chart, because what was obvious with this gentleman was that everything was focused on what he wasn't doing. And as a result, he didn't get to do anything. So we set a chart up that he could document with his workers when he agreed to have his insulin. If he had it 2 days in a row, that he would then get to go out to a place of his choice with the support workers. He's now having his insulin every day. So we don't waste the money that NDIS has put in place with nurses turning up and going away and him not having a good life. But guess whose service now they're questioning whether should be funded? Ours. Because they're meant to be able to get that from the mainstream services. So I'm just hoping that that doesn't get defunded, because that's just the first strategy we've done with this man. Give people a happier life, and they'll also end up with better diabetes management. So we look at the person as a whole, and we look at what they're eating, we look at what their how their exercise is going, and also how their stress management is going. You cannot take stress out of the equation. Here is a positivity chart that we've done as well. We find so many people with diabetes and disability are berated all the time, and they don't get told when they're doing positive things for their health. So we started doing these positivity charts where this gentleman is able to tick off when he does things in a day so he can build his self-esteem. And his staff can see that he's actually doing lots of really good things. We've got here a low literacy resource for using the Libra sensors. These have revolutionised what we can do with people with a disability now. I had a gentleman the other day who's 27 and refusing to do anything. Essentially, it feels like he's on a path to wanting to die, because his type 1 diabetes is so out of control. He doesn't know what to do with it, and he's got lots of mental health issues. He didn't realise that he could get a sensor with his NDSS, because he thought his phone needed to be more modern in order to connect the app. But you can get a reader. So we got a reader and we got a sensor, and we gave him a trial. So I dropped it into his home, always thrilled to see his diabetes educator, and left it there. And he knew how to do it, left him to it. And I got a message last week saying that he's now decided to use it, but he's administering 6 units of Act Rapid every day, Novo Rapid. That's huge for that young man, and will be enough, hopefully, to keep him out of hospital and to feel better and want to do stuff with his life. This is a check, think and act, which is something I've created that I actually use for everybody now. It helps people know if their levels are low, if they're healthy, or if they're high. So you'll notice my language is very positive. It's not if it's good, bad, or okay. You have to use positive language with this as well. So, like I say, next one, please.
And we might need to wrap up shortly as well, Jayne.
Yeah,
perfect.
So these are some more examples of resources that you can look at later. Next, please. So support workers. I've already said this. Next one.
Yep.
So the strategies we use is bringing all the team together, and that in itself can be done, believe it or not, just by bringing everyone together on an email, but you need someone to do it. So we bridge this disability health gap. We have online diabetes training so that the support workers are properly trained in all the information they need to be able to cook for people, to be able to support them to exercise, to be able to do all aspects of their glucose monitoring, whether that be and their injectable medication. We do diabetes management plans that have lots of pictures in it so that the support workers can understand it as much as their client. And then we often do a mini one for the individual. We found that we can decrease call-outs for accident and emergency with the combination of all of these resources and improve the person's quality of life, but also the support workers. And they stay longer in the services we've found where we're working. Next, please. So that is a really quick snapshot of years of work, but love to hear any questions.